Hello everyone and welcome to today's Connect and Learn webinar. I'd like to begin by acknowledging the traditional owners of the land on which we meet today and pay my respects to their elders past and present. I extend that respect to Aboriginal and Torres Strait Islander peoples listening today or in the future. My name is Rebecca and I will be facilitating today's webinar. An introduction to AOD peer work, including misconceptions, challenges, benefits, and best practice, presented by Benn Veenker. This webinar is part of a series of Connect and Learn webinars designed to support AOD clinicians throughout Victoria. Please be aware before we start that we will be recording the first 30 minutes, which is the presentation of content by Ben only. We will then stop the recording and you are open to ask questions freely of Ben, our presenter. We hope this creates space for rich conversation. The recorded presentation will be made available on the Turning Point website soon. At the end of the presentation, please take a few minutes to complete the evaluation survey using the QR code, which will be on the final slide, or it will be sent to you via email later today, also with a copy of Ben's PowerPoint presentation. Now I'd like to introduce our presenter, Benn Veenker. Ben is the Manager for Lived Experience, Workforce and Advocacy at Turning Point. Ben is a passionate recovery advocate and is consistently working at breaking down the stigma associated with substance use and mental health. Ben, thank you so much for presenting for us today.
Great. Thank you, Beck, and hello to everybody out there today. It's great to be here to be able to speak a bit about peer work and share in some of my learnings over my career as well. I suppose before we get into the presentation itself, I thought I'd share a little bit about me and who I am and share a little bit about my lived experience and my work experience because, you know, every day we have peer workers who come and bring their whole selves to work. And I think it's only fair that I do the same with this presentation to sort of set the tone as well. So for me, I found alcohol and drugs at the age of 13, and they were a fantastic solution to my social anxiety, my depression, my negative self-talk, and they really helped me fit into the world. You know, why I had social anxiety, depression, and a negative dialogue happening is a discussion for another day. But alcohol and drugs were fantastic at helping me fit in and feel at comfort with myself. Fast forward 20 years and I'm 33 years old and in a place where alcohol and drugs have just taken over my life. And I enter this period called recovery and access treatment services. And I'll talk about what that term recovery means in this context today in this presentation. So historically, before I came and entered the drug and alcohol sector, I was a landscape gardener, irrigator, and certainly on days like today when it's wet and rainy outside, I don't miss that work one little bit. But as I said, like since I did make some significant changes to my substance use, I decided to change career and enter the AOD sector. And have been working in this space for over 12 years now within various community health organisations and various AOD services, which include both Windana and First Step in St Kilda. Over my AOD career, I've held a variety of positions, you know, initially starting with peer support work, which was wonderful, which keeps me well informed for this role that I'm in now. But I've also stepped into clinical roles as well, in terms of counselling. I've also been a team leader, a manager of different programs, community-based programs and outpatient programs as well. I've also currently sit on various consumer advisory groups, most recent being the LEAP, the Lived Experience Advisory Panel for the Collaborative Centre of Mental Health and Wellbeing. And currently I sit on the Liquor Regulation Lived and Living Experience Advisory Committee for the Department of Justice and Community Safety, looking at alcohol-related harm. Which is a real privilege to be on that consumer advisory group. But above all that, I'm human. I'm a husband, I'm a father to two beautiful kids, and I'm a bit of a mad runner as well. So that certainly helps keep me sane and grounded. And I think it's important that we bring the human elements into the presentation as well. So let's get into it. So what is lived experience? Like, we all have lived experience and we are all experts with the experiences that sort of shape who we are and how we fit into the world. But if we look at lived experience from an AOD context, we look at to the ADF for their definition, and that can refer to people across the continuum of drug and alcohol use, from that early experimentation stage through to dependence and through to that period of longer term recovery or significant change. What is living experience? And I find that, being in this space for a little while now, that often those terms can be sometimes used interchangeably. And I suppose I just wanted to, bring that to attention, and also bring to attention that the essence of the work is the same if you're a lived experience or living experience, and that is to support and meet people where they're at, and provide hope and optimism potentially for the people that we engage with. I suppose the key difference there is the experience that we're drawing upon to support those individuals, be it a lived experience or a living experience. Recovery. What is recovery? And this can be a term that often can be a bit polarizing for different people. And I think for many organisations, when we look at employing lived and living experience peer workers, we look first and foremost for the AOD lived experience or living experience, but I think also we look for that period of stability. I think that period of stability or change is what we refer to as recovery, and it's certainly what I'm going to be referring to when I talk about that term recovery through today's presentation. So transitioning to a period of recovery or self-determined healing is personally defined, and everybody's definition of what that is personal to them. And I think it's important that we really recognize that and acknowledge that. So if you hear me talking about recovery today, it is that personal definition of self-determined healing. It doesn't necessarily mean abstinence. It is what one decides it is for them. So I just wanted to bring that, really put that in lights, so that when I talk about recovery, you're clear of what I'm talking about. It's that self-determined healing, which is personally defined by the individual themselves. So peer work, what is it in a nutshell? I suppose first and foremost, peer work is a non-clinical role, and peer workers use their lived experience of substance use, and then I've got here plus skills learned in formal training to support others that promotes understanding and fosters connection. So while I think it's important to note that the lived experience is the qualification. Those skills that are learned in informal training support that role. They're not necessarily a prerequisite to be in the role. The prerequisite is the lived experience. So lived experience workers or peer workers share their experiences in a way that inspires hope. So it's very intentional, very purposeful with the disclosure that happens between peer worker and the individual who's accessing the service. We offer help and support as equals and try to reduce that power imbalance that happens for people who access drug and alcohol services, who, when that, for example, might sit with a doctor or a nurse or any other clinical staff member, there is that power imbalance, and peer workers look at trying to reduce that gap. Doesn't say we get rid of it, certainly don't get rid of it, but we certainly have a great role to play in reducing that gap. Peer work is very relational, and it's about being able to build a strong relationship with the individual who's accessing the service, and demonstrate and role model the benefit and possibility of change. And I've just put finally there, we are complementary to and work really well collaboratively within multidisciplinary teams. So what does it look like? So peer work is a very recovery orientated approach. So really promoting self-advocacy and encouraging individuals to take an active role in their recovery for whatever they determine that recovery journey is for them. We use real positive role modeling. So doing what we say we're going to do, inspiring hope and using really purposeful and meaningful disclosure and really quite intentional disclosure that's relevant to the discussion that's taking place. Peer workers are really good at using a strength-based approach to support individuals accessing services. Accessing drug and alcohol services, as we know, is really hard work for people to even just get to an appointment. So peer workers are fantastic at being able to draw those strengths out that somebody might not be able to see within themselves. Being able to acknowledge the challenges of getting to the service, acknowledging the barriers that they've overcome to connect and to get there in the day. So I think peer workers are fantastic at doing that and really good at helping people identify the different services that are out in the community. Our AOD service system can be challenging at times to navigate. And I feel our peer workers who've been there, done that, can really help individuals understand what's available to them and share with them what might work, what might not work as well, and helping them align those services to what their goals are with their recovery. So, a real quick example of what peer work might look like in a detox setting. So, Tom has struggled with addiction for years, always feeling like he had to fight it alone. When he entered a detox service, he met Josh, someone who'd been in recovery for 3 years. Tom didn't know that there were people who lived their lives in recovery. Josh could see Tom was nervous and anxious about being at his first detox. "I've been where you are," Josh said. "It's tough, but it gets easier. And I'm here if you want to chat." Although hesitant, Tom agreed to talk over the coming week, and they checked in, supported each other, sharing similar thoughts and fears about life, and setting a direction to head towards. On tough days, Josh reminded Tom of his progress. Tom began to see that recovery wasn't about doing it alone, and Tom felt safe with Josh and therefore felt safe within the service. And just within that short description, you can sort of see some of those key elements of peer support there. That strength-based approach, helping them identify what a recovery journey might look like, purposeful disclosure. And I love that last bit there about Tom feeling safe with Josh and therefore feeling safe within the service. And I think that's a big part of what peer work is about helping people feel safe and supported in a service. So I'm just going to go a little bit broader now and talking about a little bit about the lived and living experience workforce in general. And while there's many definitions of what the lived and living experience workforce are, the Department of Health define it as the lived and living experience workers work across a wide range of areas, including peer work, system advocacy, consulting, learning and development and academia. And within the drug and alcohol sector, I think we've really noticed over or historically that we've really lacked with a framework to support this workforce and peer workers and lived experience workers. And recently there has been the release of the lived experience discipline frameworks across the variety of disciplines from AOD, harm reduction, and mental health. And these documents that were released earlier this year a real crucial document to help organisations understand what lived experience work is and how to embed lived experience workforces into their organisations. So I certainly encourage anyone who hasn't seen these documents. There's 5 frameworks relevant to the lived and living experience workforces. The one specific for AOD is the AOD Lived Experience Framework, and that contains Victoria's AOD Lived Experience workforce history, underlying values, skills, knowledge base, and scope of practice as well. So a really important document to become familiar with and helps shape the way that you embed peer work within your organisations. I should really mention there the key organisations that went in the development of those frameworks, Shark, Tandem, Harm Reduction Victoria, the Centre for Mental Health Learning, and the Carer Lived Experience Network, or CLEW, in partnership with the Department of Health as well. So you can access those documents on the Department of Health website. If you're looking specifically for AOD, head to Shark's website and you will find them on Shark's website. So as I've got there, it's a really crucial document, or they are really crucial documents for supporting effective integration of lived experience roles. They provide that real role clarity for what lived experience work looks like, purpose, training opportunities. It's a great document to use to explain what lived experience work is for staff who aren't in or not familiar with lived experience workforces, or who haven't worked alongside a lived experience workforce. So yeah, really crucial documents and very timely to be released early this year. So benefits for having a lived experience workforce across your organisation. It can certainly improve your organisation's culture and enhance that recovery focus and bring that lens right within your clinical teams. Like working with lived experience staff helps other staff understand that the people that they care for can and do recover or make significant change and can live a different lifestyle. And therefore, this obviously improves empathy and understanding towards people who access drug and alcohol services and the carers who support those individuals as well. Because, I've worked in clinical roles as well. And sometimes when you're working with people who are accessing AOD services, we can experience really challenging behaviours as people navigate the difficulty of living life and managing their life with substance use. But having that lived experience team and presence around you reminds you why it's important to keep plodding away and doing the work you do and turning up every day for those people who need our support. So our lived experience workforce also role model hope and recovery, and the visibility of peer workers as staff members certainly helps reduce stigma and improve trust and safety for those people who access our services. And I touched on that before. Like it's so, I feel it's really important if we have services where peer workers, lived experience workers can almost be that first point of contact for individuals who are accessing our services. And we have it here at Turning Point. We have peer workers who work within our walk-in service, and it's such a great reassuring time for people who present often very nervous, very anxious, full of guilt and shame, and to have someone sit there and be able to validate, understand, and normalize the experience is very reassuring and very comforting for those people. And just finally, the lived experience workforce, obviously with agreement, can also assist with training and supporting staff, providing a lived experience perspective within our team meetings and multidisciplinary meetings or clinical reviews, can be engaged in subcommittees as well as policy and project and research development. And that's, again, more broadly the lived experience workforce I'm talking about there. Some of the challenges for our peer workers and our lived experience workforce, which I think it's just nice to be mindful of, is the boundaries, navigating that fine line between disclosure and sharing very personal experiences with people and maintaining that relationship can be challenging. And it's important that we have regular spaces where our peer workers can reflect on the work that they're doing and how they're doing it with relevant peer-led supervision as well. So this is a challenge that often comes up for peer workers. Being in a peer worker role is obviously, there's no choice whether you disclose whether you have had an experience that's impacted your life around drug and alcohol use. So having the words lived experience or peer in your job title automatically discloses that you've had those experiences. So, some days that's no problem. I turn up and we do the work and we love the work. Some days that's really challenging. And I think it's just to be mindful of that forced disclosure that happens within these roles. Self-care, I think self-care is we really need to be mindful of the importance of self-care for our peer workers and allocating time for that to take place. To maintain and to reduce that chance of burnout and staff turnover, that we help people identify what is it that helps you stay grounded, that helps you be able to turn up every day. What is it within the workspace that we can provide to help you in that space? And they can be simple things like just, time out to go for a walk, have a coffee, connect to people who are in the same roles. So finding out what is the self-care strategies for the individual and supporting them with making sure that we engage in those practices. Some other challenges that I've certainly noticed is lack of understanding of what a peer worker does, and which then can lead to being asked to do tasks or duties that fall outside the scope of practice. And not saying we can't do that stuff, but it can, if it doesn't, if those loads aren't shared around, then it can certainly erode what peer support is all about, and we can sort of potentially default into other roles. So it's really important that, like the frameworks that we have now, that those are really communicated to staff and that staff have a good understanding of what peer work is and the value that it adds to the team, to the clinical team. And if I look again at clinical teams, often some of the challenges we come across is the language that's used, the abbreviations, the acronyms, the medical terms. They can be really hard to get your head around. We've got one peer worker that I know of who has pages and pages of acronyms, medical terms that he uses to sort of keep himself across it all. So just being mindful of that when you have lived experience or peer workers who aren't familiar with clinical jargon, that we're taking the time to explain what that is. Common misconceptions for our lived experience workforce is that we're fragile and likely to relapse. Some of the most resilient and hardworking individuals I've come across are people with lived experience. So certainly we're no more fragile than anybody else in the workforce. And I certainly would caution, that white glove approach to peer workers. We are resilient, and we do know our limits. But again, like any employee, we love support and supervision as well. There's no difference between lived experience workers and other staff that have a personal experience of AOD use. Now, we know that there's a lot of people in our sector who do have a lived experience, be that in a living or lived experience role or a carer role. It's what brings a lot of people to this space. A lot of really good-natured, dynamic people. I love this sector for that. But there is a big difference between working in a lived experience role or working in a non-designated lived experience role with lived experience. We bring our whole selves to the workplace when you're in a designated lived experience role. There's no shutting off or being able to sit behind a job title of maybe a counsellor or a clinician. We bring our whole selves to the space, and that can be quite draining. So it's important that we do notice there is quite a difference there. Lived experience workers cannot work full time due to the level of responsibilities and stress. No, that's certainly not true. I know plenty of peer workers who work full time. I think often what happens is that the funding that people have and the money that organisations have is often very tight and limited. And we might have one EFT allocated to a team. But I think what we do is we decide to, which I think is great, is split those roles into maybe a 0.5 and a 0.5 or a 0.6 and a 0.4, so that we have two staff that can work over and cross over and work together, which I think is really important. But there's certainly no reason that we can't have full-time peer workers. Anyone who's received AOD treatment will make a good peer worker. Certainly not the case. Just because you've accessed services doesn't mean you're the best person to be a peer worker. And I think we can identify this through our recruitment processes that we implement. And being a peer worker takes a level of skill, a level of resilience, and a level of work and insight and self-reflection that not everybody has. So I think, we need to be careful when we're considering the people that we're putting into these roles, and that we've got those structures and supports in place when we do put them in those roles. Organisations need special policies for lived experience workers. No, we just need good policies across the board for everybody who works in our organisation. And I think that's all I need to say about that. I mentioned before around lived experience is the qualification, but there are also frameworks to support our peer workers that we have within our services. And I suppose the one that I suppose is looked at as minimum standard these days is around intentional peer support training, or IPS, as a lot of people refer to it. Operated out of Shark, the IPS hub. The core training is 5 days, and the advanced training is 3 days. But certainly not necessarily for certain roles a prerequisite to becoming a peer worker. But we certainly encourage within Turning Point that our staff have engaged in IPS training to help support the roles that they do when connecting with individuals. We've also got there the Cert for Mental Health Peer Work offered at various tertiary educators, which has various electives around AOD and working with youth. Just quickly on IPS, and I know I'm running short of time, is that IPS is as I said, the model or a framework for creating relationships where both people learn and grow together. And it's used worldwide, born out of the US. And it consists of 4 tasks. And I just really want to just bring these to your attention. I can't obviously go through these in great detail, which is covered in 5 days of training. But this is, I suppose, the fundamentals of IPS and what peer work is about as well. It's about building connection with somebody. It's about being able to talk to someone and find those common grounds, and build trust. It's about noticing when connection has fallen away and being able to role model and call it out and go, what's happening there? Like, why have we lost connection? It can always come back, but it's really role modeling. So connection is that foundation. Then we look at understanding worldview, which is understanding how, first and foremost, what's our worldview? How did we become to view the world that we do? But also being able to understand where someone else's worldview might come from and trying to understand that on a deeper level to build our relationship with that person. It's about mutuality, building a relationship that works for both of us. This is a two-way street when we talk about peer work, working with someone else. As it says, they're different from one way. It's where we both contribute to the relationship, we're both accountable, and we're both moving towards something which is defined by both of us. So that's IPS in 10 seconds, which you'd actually need a lot more. But that sort of gives you a bit of an overview of the framework that peer workers will often work around and work with. Just to finish, I just wanted to bring a case study, a really brief case study. This has been all de-identified, but it is a real life case study that one of our team agreed that we could use. So just quickly, Jane is a 37-year-old female who's had multiple admissions to a SECU, a secure extended care unit, in the context of psychosis due to her methamphetamine use. Currently on an involuntary inpatient treatment order from a community mental health team. So got significant mental health history around schizoaffective, borderline personality disorder, bipolar, substance use disorder, substance-induced psychotic disorder. Current treatment plan is that she is refusing all medication and treatment. Substance use, polysubstance user, with methamphetamine being her primary drug of choice. If we look at the social aspects, we've got homelessness, limited engagement in the community, and no support from family and friends. Employment, she's currently unemployed, is a high achiever, and has been previously employed as a physiotherapist. In terms of stages of change and treatment goals, when engaging with the clinical team, not ready to engage in any AOD services, and has a history of aggressive behaviour towards clinical staff and emergency services. So this person was referred to one of our peer workers in one of our clinical teams. So just going to run through what that looked like. So The first session was all about rapport building and building connection with Jane through active listening and relevant self-disclosure. So disclosing what is relevant to what she was talking about. Jane, throughout that, towards the end of that session, was able to identify that harm reduction was her goal around her journey. And that was certainly accepted and encouraged and acknowledged for her choosing to determine what her goals are. The second session was about providing her with some more information. So this is now that two-way street. So we're providing information about harm reduction techniques with methamphetamine use, including education around NSP, bringing awareness around the injecting rooms, understanding tolerance, misadventure, and overdose. The third session that they had was around health promotion and starting to introduce community services and pro-social groups like peer support groups, smart recovery, which led into the fourth session around what her plans were around discharging from SECU, and had a discussion around what that might look like for her. Certainly not being directive, but bringing a discussion around what is housing looking like, what's your diet going to be looking like, and exercise. And the fifth session, which was surprising for this peer worker when we were talking about how the peer engagement process was going, was that she asked the peer worker about their journey of recovery and what that looked like and what they did in their journey. And I think that sort of speaks to the power of role modeling and turning up and being accountable and being present and being able to use purposeful self-disclosure and relevant disclosure. It brings an inquiry for the individual. So from Jane, the peer support goals that we felt were achieved were around empowerment, with her deciding on a harm reduction pathway that she wanted to take. And we certainly encourage that and encourage her to take a real active role in that recovery journey for her, with a focus on hope and resilience rather than just sort of managing symptoms, which we need from our clinical teams, but we certainly don't need that from our peer workers. Engaging in promotion of relevant peer support groups, and then looking at that stigma reduction piece around, sharing openly around lived experience, and displaying real understanding and empathy for where she was at with her recovery journey. So that's it from me in a nutshell. I know I covered a lot of information and I can speak a bit quickly, but thank you for that. Thank you for your time and thank you for your listening.